Welcome to the New Retina Radio Journal Club with VBS. My name is Lediana Goduni from Retina Associates of Cleveland, and I'm joined today by my two colleagues, Dr. Alexis Warren from University of Chicago Medicine
Thanks for having me.
and Dr. Joshua Ure from Wills Eye and Mid-Atlantic Retina.
Hi, Liliana.
All right, so today we're discussing a paper entitled Glucagon-like Peptide 1 Receptor Agonist Impact on Chronic Ocular Disease, including Age-Related Macular Degeneration by Kevin Allen et al. And this was published online in Ophthalmology in January of 2025. And Dr. Ure is now going to summarize this paper for us.
Great. So the purpose of this study was to investigate whether GLP-1 receptor agonists influence the risk for age-related ocular diseases, including macular degeneration. So it's a retrospective cohort study from the TriNetX database, which is a collaborative network of aggregated, de-identified EHR data from over 60 contributing healthcare organizations. And the authors queried this database from 2010 to 2023. They included patients over 60 who saw an ophthalmologist and had follow-up and medication prescriptions for at least 5 years. They divided these patients into 5 cohorts based on prescribed medications, and those cohorts were GLP-1 agonists, metformin, statins, insulin, and aspirin. They did propensity score matching on 13 patient characteristics, including demographic and medical history data, and they looked at the outcomes of new onset ocular conditions based on encounter diagnosis codes, and these were compared between the cohorts at 5 years following medication initiation. So the 5 conditions they looked at were cataract, ocular hypertension, primary open-angle glaucoma or POAG, non-exudative AMD, which included early to advanced stages, and exudative AMD. They also performed 3 additional validation analyses. So the first was they validated the time course results by performing independent analyses with propensity score matching populations at 3 years of medication use. The second was they performed a separate analysis for POAG, where they included propensity matching for ocular hypertension and glaucoma suspect diagnoses at baseline to control for POAG risk factors. And the third was they repeated the original 5-year analysis, but for an older cohort, patients 75 and older, since macular degeneration typically has an older age at onset. So the findings, there were 9,669 patients, 60 years of age or older, with at least 5 years of ophthalmology follow-up and GLP-1 receptor agonist use. The baseline characteristics of this cohort were that 84.4% of these patients had diabetes. They had an average BMI of 36.2. They had an average age of 61.1, which was younger than the average age for the other medication cohorts, and this was statistically significant. They were 59.9% female and 59.9% white, which are higher percentages than for the other medication cohorts, also significant. And they had overall higher rates of chronic conditions, including obesity and hyperlipidemia, compared to the other medication cohorts. So at 5 years, GLP-1 receptor agonist use was associated with a reduced hazard of developing non-exudative AMD compared to all other medications, again, including metformin, insulin, statins, and aspirin, and the hazard ratios here ranged from 0.6 to 0.72. GLP-1 agonists were compared to the insulin group, and there was a significant reduction in the hazard of wet AMD and POAG in this comparison, with hazard ratios ranging from 0.62 to 0.79. At 3 years instead of 5 years, GLP-1 agonists were also associated with significant reduced hazard of developing non-exudative AMD compared to metformin, insulin, and statins, with hazard ratios ranging from 0.66 to 0.69. And compared to the insulin group, GLP-1 agonists showed a significant reduction in POAG and wet AMD, with hazard ratios from 0.58 to 0.72. There was a minimal impact of GLP-1 agonists on the risks of POAG compared to statins and of exudative AMD compared to metformin users at any time point. And the authors conclude that GLP-1 agonists may reduce the risk of multiple age-related ocular conditions, including macular degeneration.
Great. Thank you so much, Dr. Ure, for summarizing that paper for us. And I'll jump to Dr. Warren for a quick response here to this paper. And Dr. Warren, do any of these results surprise you, or what is your first reaction to this paper?
Yeah, I think I'm not too surprised by this. I think all of us can agree that GLP-1s have really been considered kind of a wonder drug, especially in the last couple of years for our patients. So, that's good news to know that maybe in addition to helping them with some of their systemic conditions like diabetes and obesity, it can also help with some of these eye conditions that we see and treat very regularly. I think the thing that we have to think about is what does this mean and who were we looking at in this study in particular? I think big kudos to the study that it was a large database, that they got a lot of information, that they looked over several years, 5 years of looking into these ocular conditions. And they did the best they could with the groups that they had for propensity matching and trying to make sure that the groups looked similar to each other. But I think we might want to scratch our heads a little to think of how does this really compare to the patients that we're seeing in our clinics, in the greater populations, and how can we extrapolate this data to the people that we see every day?
Great. That's a great points that you have there, and I think perfect segue after our discussion. So we'll take after the break. So we'll take a quick break, and then we'll come back for a more in-depth discussion and jump off of some of the points that Dr. Warren has just made. So join us in a bit.
Support for this podcast is brought to you by Genentech, the maker of Vabysmo, faricimab SVOA. Do you follow us on LinkedIn? You should. Stay current with our latest updates and hear from leading experts as they share their real-world experiences. Search Vabysmo, that's VABYSMO, on LinkedIn to find out more and give us a follow.
All right, welcome back to the New Retina Radio Journal Club with VBS. So we'll get into a longer discussion about the paper that Dr. Ure summarized in the first part of this episode. We'll start with Dr. Warren. So GLP-1 usage has exploded recently, it seems like, in the last couple of years. Do you anecdotally notice that more of your patients are on these agents? And do you feel like you've seen any clinical differences between patients on the GLP-1 agonists versus the ones who are not?
Yeah, I mean, I would say a lot of my patients, probably a majority of my patients nowadays that are able to have access to them are on this medication. I'd say anecdotally, I don't know that I've seen enough of them or seen them in succession enough to have seen a change in disease progression. But with papers like this, I'm encouraged that maybe I will, or lack of disease progression, I guess. I think the question is really who are the patients that are on them, and how can we counsel them on what to expect or not expect. But I think we need a lot more data on that to really be sure.
Right. Yeah, that's great. I feel like for me, it's maybe like about half of the patients that are on it. And like you said, it's hard to say right now. Definitely in the short term, like you see them, 3 or 6 months later, and they do have meaningful reductions in their A1C. But Dr. Ure, what is your experience?
Yeah, so I don't know how many of my patients are on these in terms of a percentage, but certainly many. These medications have really boomed in popularity. Um, it's too soon, I think, to say anecdotally what kind of effect they're having on our patients' diseases. Many of these patients have not been on these medications for a long time. It's really hard to say. I can't say I've anecdotally noticed any differences in that respect. Another important thing, and this wasn't the point of the paper, but another important thing for us to consider for these medications and any proceduralists is that they delay gastric emptying, so it can affect your anesthesia. It increases the risk for aspiration. So I know that's not the purpose of this study, but important for us practically, for our patients who need surgery.
I think that's actually a great point, especially for the diabetic patients. Yeah. So when you guys think about this paper and the patients that are on it, do you feel like there's any limitations to the study in terms of like who they included in the study, or the types of patients that may or may not have access to these medications and how that might influence what was shown in the paper? Dr. Ure, what do you think?
Yeah, so that's a good question. And the authors do point out that with the TriNetX database, they can't control for socioeconomic status, which may influence who takes these medications and also certainly can influence disease status and progression, as we know from many studies. So this is a big factor that's not controlled for. So it's hard to say how much effect socioeconomic status has, on who's using these medications, who has access to these medications, and what interaction it has with these medications in terms of altering disease. It's just an unknown at this point.
Yeah, great points. And Dr. Warren, anything to add to that one?
Yeah, I mean, I totally agree. I think for me, I practice in the heart of the South Side of Chicago. So that's really important because my patients who are on this or who do or don't have access, that may be a totally different cohort of people and a totally different type of disease progression. So it's definitely something that gives me pause in this paper. And I know they did the best they could with the data that they have, but it's important when we're critically analyzing these papers to think about that. How much does that match the population we serve? How much does that match the population of the country or, the places around the world and how the disease that we really see in our real clinics.
Yeah, great. That I think that's so important when you look at all these papers is the generalizability of the results of the patients that were studied to your practice and to the different areas of the country. So I think those are great points. And the point about socioeconomic factors is these costs, these drugs are obviously, very expensive. So that's super important to keep in mind. So additionally, in this study, neither diabetic retinopathy nor DME were studied. So what results do you guys expect that research on these relationships would have on these diseases? Dr. Warren?
Yeah, my hope would be that this would have a good response. I think we know systemically for our patients that these GLP-1s really do a great job in doing well with their A1Cs, their weight loss. So overall, we see systemically that this medication is working. I would hope that in the same sense, that might help to decrease their disease progression in diabetic retinopathy. That would be my hope. Although we know there is this association with a great reduction in your A1C or your sugar control and kind of an increase in diabetic retinopathy. So I think it would be interesting, and that's something that I definitely would love to see more studies and have more data on. And I think that would be helpful for counseling our patients on what to expect and maybe thinking about how often, the frequency that we see them, and kind of the treatments that they may need in the future.
Yeah, that's great. And what about you, Josh? What do you think?
Yeah. So there's some thought that these medications can temporarily worsen diabetic retinopathy because of the rapid glycemic control. Some studies do show that, but the data on that's actually mixed. There's other studies that don't really find that. But in any case, I think the important point here is that long-term better glycemic control will lead to less diabetic retinopathy, less severe retinopathy, less DME. And I can't tell you how many times I have a conversation with someone who says, "Oh, I'm on this medication now, and my A1C is great, right? It's 6.5. Why do I have this swelling, right? Why do I have this bleeding, right?" And I say, well, this is really a reflection of what your diabetes was and what your sugar control was 5 or 10 years ago. And I'm glad your A1C is better now, and that's going to keep your eyes as healthy as possible going forward. But we're dealing with the consequences of the past, right? So if more people are on these medications and have earlier and better glycemic control, I think that will really help with the retinopathy aspect of this long term.
Yeah, great. And that's why I asked, 'cause I feel like the majority of my patients that are on these medications are diabetic patients. I feel like I'm not actually 100% sure on how many just AMD patients are on these for other reasons like obesity. So it's kind of hard to, you know, I guess, know that for sure. And in that population, they don't necessarily always overlap. Diabetes is mostly younger patients, and our AMD patients are older. So, um, when you do have patients who have dry AMD and they are obese and happen to be on these medications, do you guys, do any additional counseling? Or if they're not on these medications, do you, kind of advise about seeing their doctor to kind of manage obesity and what can be done about that to decrease the risk of progression? or, to more, um, significant stages of macular degeneration. I don't know what you guys do with the information from this paper for your macular degeneration patients. Dr. Warren?
Yeah, I think the great point you make about that is I don't know what to make of it. I think honestly, this isn't a medication that I would prescribe for someone to try to keep them from having disease progression of POAG or of AMD. This would be a medication that maybe if I saw on their list and I knew they also had these ocular conditions, I might be somewhat happy or might say, stay on that medication as long as it's working for you otherwise. But I'm not sure my role as an ophthalmologist, as a retina surgeon, how I play into getting them on this medication or encouraging them to start this medication. It's not something I would say I'm comfortable with at this point.
Yeah, totally agree. And just to wrap up this segment, Dr. Yu, what do you think about that? Or do you have anything else to add?
No, I mean, I agree. This isn't a medication that I would be prescribing. And I think the data here are, they give us good food for thought, and it's a starting point, but they're not compelling enough to make me start recommending that patients should take this, right? I mean, the only thing I think that would help me cross that threshold would be a real clinical trial, something similar to AREDS, right? That really showed definitive benefit. And that's a very hard trial to run. Um, but short of that, and this paper doesn't move the needle for me in terms of what my recommendations are.
Great. Well, thank you guys so much for your wonderful discussion on this paper, and thank you to the audience for listening to this episode of the New Retina Radio Journal Club with VBS. And please stay tuned for further episodes.